Picture this. You wake up one morning feeling that all too familiar heaviness deep in your lower belly. You head to the bathroom, sit down, and you wait. And you wait, and nothing happens. You strain a little harder, still nothing. You think, maybe I just need another cup of coffee. So you get up and try again an hour later. Same result. By the third or fourth attempt, something has shifted, and not in a good way. Now there is real pain. A deep, dull, almost throbbing ache that radiates from your lower back all the way down into your pelvis. You begin to feel full, bloated, almost feverish, and a quiet but insistent voice in the back of your mind starts saying, something is seriously wrong. If that story sounds familiar, if you are watching this right now, and that scenario hit a little too close to home, I need you to stop whatever else you are doing and pay very close attention to the next 18 minutes. Because what I am about to share with you could genuinely save you from a dangerous, potentially life-threatening medical emergency. My name is Dr. Danielle Morgan, and today we are having the conversation that nobody wants to have, but that millions of people, especially adults over the age of 60, desperately need to hear. Today's topic: stool that is physically stuck inside the rectum. What is it? How does it happen? What are the warning signs your body sends before it becomes catastrophic? And most importantly, what do you do about it right now, step by step? I give you my word, by the time this is over, you are going to understand your own digestive system in a way that most doctors have never taken the time to explain to you. And that understanding is going to be one of the most valuable things you carry out of this conversation. So take a slow breath, get settled, and let's get into it. Before we go further, I want to hear from you. Where are you watching from today? Drop your city or your country in the comment section. I read through them, and it genuinely matters to me to know who is part of this community. Now, let us get into it. And I want to start not with the solution, but with the problem itself. Because here is the mistake most people make. They treat digestive issues the way someone treats a dripping faucet. Ignore it, stick a bucket underneath, hope it sorts itself out. But what we are dealing with here is not a leaky faucet. This is a pipe that is completely seized. And understanding precisely why that happened is the key to fixing it right now and making certain it never happens again. The medical term for what we are discussing is fecal impaction. Set the clinical label aside for a moment. In plain terms, here is exactly what is happening inside your body. Your large intestine, that 5-foot muscular tube winding through your abdominal cavity, has one primary job: to absorb water from whatever passes through it. It is extraordinarily efficient at this task. The problem arises when stool sits inside the colon for too long without advancing. Your body does not recognize when to stop extracting moisture. It keeps pulling water out hour after hour, day after day. What begins as soft, manageable waste gradually becomes something with the texture and density of hardened clay. Here is the part that catches most people completely off guard. This situation almost never develops suddenly. It is not a switch that flips from fine to emergency overnight. What actually happens, especially in older adults, is a slow, deliberate progression that builds over 3, 4, sometimes 7 or 8 days. During most of that window, you may feel only mildly uncomfortable, a little full, perhaps slightly sluggish. You might still be going to the bathroom, but each time, you are passing only a fraction of what your body needs to eliminate. A portion gets out, a significant portion stays behind. The next day, the same thing. And the day after that. Think of it like this. Imagine pushing a large, rough, irregularly shaped stone through a garden hose. That stone is not going to slide. It is not going to compress. And the harder you push, the more firmly it wedges in. That is the mechanical reality inside your lower digestive tract. And the harder you strain on the toilet, the more you are compressing that mass rather than dislodging it. Now here's what I need you to understand clearly. And this matters most for older adults. After the age of 60, several physiological shifts occur simultaneously that dramatically increase the risk of fecal impaction. Intestinal muscle contractions naturally slow down. Pain perception in the gut becomes less precise, meaning you may not register urgency signals the way you once did. Many seniors are on medications, blood pressure drugs, pain relievers, antidepressants, iron supplements, even calcium, that significantly reduce motility. And the natural thirst reflex weakens with age, leading to chronic, low-grade dehydration that the body no longer even registers as thirst. This is not a personal failure. It is not your fault. It is a convergence of biological changes that most people were never properly warned about. And my job here is to fix that. Before we continue, take a second and tell me your name and where you are tuning in from. I go through the comments because I genuinely want to know who I am speaking to and what I can do to support you. Now, I want to take a deliberate moment on this next section because the symptoms of a fecal impaction can be profoundly misleading. Getting them wrong can cause people to take exactly the wrong action, which makes everything dramatically worse. The first confusing symptom, watery liquid discharge. Stay with me here because this is the one that sends the most people in the wrong direction. You might be sitting there right now thinking, I am not constipated. I actually have diarrhea. Here is the truth. When a solid, rock-hard mass of stool completely blocks the rectal passage, the newer, looser waste coming down from higher in the colon has nowhere to go. So it does the only thing it can. It seeps around the edges of the blockage and leaks out as watery liquid. This is called overflow diarrhea or paradoxical diarrhea. It tricks people into believing they have a stomach bug or a GI infection rather than a blockage. The danger is this. People reach for anti-diarrheal medications. And those medications, the kind that slow intestinal movement, are absolutely the worst thing you can take in this situation. They do not just suppress the liquid output, they slow the entire digestive system, allowing the impaction to harden further and grow larger. If you have watery discharge alongside a heavy, aching sensation of rectal fullness, do not touch anti-diarrheal medication. I cannot emphasize that strongly enough. The second confusing symptom involves your bladder. This one surprises nearly everyone. You may find yourself suddenly struggling to urinate. The urge is there, you go to the bathroom, but only a painful trickle comes out. Or you feel the need to go every few minutes and produce almost nothing. This is not a coincidence. Your rectum and bladder are anatomical neighbors. They share a confined pelvic space. When the rectum is distended and swollen with a large hardened mass, it physically compresses the bladder wall from behind, partially obstructing the urethra and making normal urination difficult or impossible. In severe cases, this urinary retention becomes a medical emergency in its own right. The third symptom that gets overlooked is lower back pain, a deep, nonspecific aching in the lumbar region that seems completely unrelated to your bowel. Most people assume they pulled a muscle or that arthritis is flaring. But when rectal pressure builds to a significant level, the pain radiates outward into the lower back, down into the thighs, even into the hips. If you are experiencing unexplained lower back discomfort alongside any bowel irregularity, that combination is a red flag. Treat it as one. The fourth symptom, especially critical for older adults, sudden changes in mental clarity or confusion. I know that sounds unrelated, but there is substantial clinical evidence showing that in seniors, significant bowel obstruction can contribute to what looks like a cognitive episode, disorientation, mild confusion, unusual agitation. This occurs because of the systemic physical stress the body is under, combined in some cases with early toxic buildup. If an older family member seems suddenly and inexplicably off mentally, always consider their bowel status as a contributing factor. It is a clinical reality that gets missed far too often. If this is the kind of information nobody ever gave you, hit subscribe right now. Because there is a great deal more where that came from, and what comes next you genuinely need to hear. Let me be direct with you now, because I believe you deserve clarity, not softened language that dilutes the message into something that fails to land with the gravity it deserves. A fecal impaction is a genuine medical emergency, not a nuisance, not something to simply wait out. If left unaddressed, the consequences escalate in a predictable and very serious pattern. Stage 1. The intestinal wall, which is living muscle tissue, becomes severely stretched beyond its functional capacity. Blood supply to that stretched tissue begins to diminish. The muscle starts losing its ability to contract and push waste forward. Clinically, we call this an ileus. That section of bowel goes quiet. Stage 2. As pressure continues to build, the distension spreads upward, affecting higher sections of the colon. What began as a localized rectal impaction evolves into a broader colonic obstruction. Nausea and vomiting begin. Abdominal distension becomes visible. The person looks and feels genuinely unwell. Stage 3, and this is the one I need you to hear clearly, is bowel perforation. The intestinal wall has physical limits to how much it can stretch. When those limits are exceeded, the wall tears. And when that happens, the contents of the bowel, fecal material, bacteria, toxic byproducts of digestion, spill directly into the sterile abdominal cavity. What follows is a rapidly progressing infection called peritonitis. It is life-threatening. Without emergency surgical intervention, it is fatal. I am not sharing this to frighten you. I am sharing it because the stakes of ignoring this condition are real, and you have every right to understand them. The window between serious but manageable and life-threatening emergency is not as wide as most people assume. So what does the danger zone actually look like? Here are the signals that mean you need to call emergency services or get to an emergency room without delay. A rigid, board-like abdomen that is tender to the touch. A high fever above 101 degrees Fahrenheit. Sudden, severe abdominal pain that is constant and worsening, not crampy and intermittent. Complete inability to pass gas at all. Vomiting that does not stop. Or any sudden drop in blood pressure accompanied by confusion and cold, clammy skin. These are not wait-and-see symptoms. These are go-now symptoms. All right, let us shift from the why to the what do I actually do right now? Because information without action serves nobody. Here is a clear, logical sequence you can follow, starting tonight if necessary. The very first thing I need you to do, and I cannot stress this strongly enough, is stop straining. Every time you bear down hard with a solid impaction blocking the exit, you are not helping. You are increasing intra-abdominal pressure, irritating already inflamed tissue, and risking hemorrhoids or small rectal tears. Straining has never, in the history of human medicine, dislodged a hardened fecal mass. So we stop doing that right now. Step 1. Lubrication and softening with glycerin suppositories. Your first at-home intervention is adult glycerin suppositories, available over the counter at any pharmacy without a prescription. Here is the crucial piece of information most people do not know. For a significant impaction in an adult, a single suppository is rarely sufficient. The standard protocol for a hardened rectal blockage involves using 2 to 3 suppositories simultaneously. One alone simply may not generate enough lubricant to coat and soften a large, dehydrated mass. Here is exactly how to do this correctly. Do not stand. Lie on your left side. This position, called the left lateral decubitus position, aligns the sigmoid colon and rectum in a way that allows gravity to assist rather than fight against you. It also takes direct pressure off the rectal area. Apply a generous coating of a water-based lubricant to each suppository before insertion. Do not skip this step. The tissue inside your rectum is already irritated and inflamed. Dryness makes everything more painful and more difficult. Gently but firmly insert all 3 suppositories as deeply as possible, pressed up against or alongside the hardened mass, not near the entrance where they will simply fall out. Then, the most important instruction: lie still. You must hold that position for a minimum of 30 minutes, ideally 45. The glycerin needs time to melt at body temperature, disperse, and penetrate the outer surface of the impacted mass. It also needs time to stimulate the rectal wall to increase its own secretions. If you get up and rush to the toilet after 5 minutes, you have wasted the suppositories and accomplished nothing. After your 30 to 45 minutes, rise slowly, go to the bathroom, and allow your body to work without forcing anything. If there is movement, good. If not, stay calm. Do not be aggressive. Step 2. Rest, walk, and repeat. If the first round produces no movement, give your body a full hour of rest. Stand up, walk gently around your home. Drink a full glass of warm water. Warmth helps relax intestinal muscle. Then lie back down and repeat the suppository process exactly as described. A second round is frequently what breaks through. The first application often softens the outer layer. The second round reaches the core. If you are still here and finding real value in this, type the number 2 in the comments. It lets me know you are watching and that this information is landing. Step 3. If home measures fail, go in. I want to be unambiguous. If you have completed 2 full rounds of the protocol I just described, waited the appropriate time, and there is still no movement, or if you are experiencing any of the emergency symptoms I outlined earlier, it is time to go to urgent care or the emergency room. That is not a concession. That is the correct clinical decision. At the hospital, the medical team has access to clinical-grade enemas using larger fluid volumes delivered under controlled pressure, reaching further into the colon to break apart the mass from above. They also have imaging tools to assess the full extent of the blockage and evaluate whether there is any risk to the bowel wall. Step 4. Manual disimpaction. In cases where all other interventions fail, a specialist will perform what is called manual disimpaction. I want to be transparent about this procedure because it sounds alarming, and knowing what to expect removes unnecessary fear. The physician will physically break up and remove the hardened mass digitally, that is, with gloved, lubricated fingers. In cases where the impaction is severe and surrounding tissue is significantly inflamed, this is not done while you are fully awake. You will be given appropriate sedation or anesthesia to prevent pain and allow the rectal muscles to fully relax. It is a serious procedure, but it is a safe, well-established clinical intervention. And the relief that follows, the immediate, dramatic drop in pressure and pain, is described by patients as profound. Clearing the current blockage is essential, but I would be failing you if I stopped there. Because if we do not address the conditions that created this situation, you will be back here, probably within weeks. And after the second episode, the third comes even faster. This is how chronic fecal impaction becomes a repeating cycle that worsens with every round. So let us talk about how to genuinely protect your digestive health for the long term, especially if you are over 60, when the biological factors I described are actively working against you. Number 1. Hydration is not optional. It is the foundation. Water is the single most important variable in preventing stool hardening. Your large intestine extracts water from waste as its primary function. If you are not consistently giving your body sufficient incoming hydration, there is simply not enough moisture in the waste stream to keep stool soft as it travels. The challenge for seniors is real. The thirst reflex genuinely diminishes with age. You can feel completely fine and have no sense of thirst whatsoever while being chronically dehydrated at a cellular level. The practical direction here: do not wait until you are thirsty. Drink 6 to 8 glasses of water throughout the day. Begin each morning with a full glass before you eat or drink anything else. That morning glass activates what is called the gastrocolic reflex, a gentle wave of intestinal movement triggered by fluid entering an empty stomach. It is one of the most natural, medication-free tools you have for encouraging regular morning bowel movements. Number 2, movement matters more than most people realize. Your intestine is not a passive tube. It is muscular tissue that moves waste through a rhythmic, wave-like contraction process called peristalsis. And here is something most people do not know. Physical movement of your body directly stimulates peristalsis. A 20 to 30-minute walk after meals, even gentle, comfortable walking, has been clinically shown to significantly accelerate intestinal transit time. For older adults with mobility limitations or chronic pain, even chair exercises, gentle torso rotations, or basic yoga stretches can keep intestinal muscles engaged. Prolonged sitting, especially after eating, is one of the most underestimated contributors to constipation in seniors. Number 3. Review your medications with your doctor. This one is non-negotiable. A wide range of commonly prescribed medications, opioid pain relievers, calcium channel blockers, iron supplements, high-dose calcium supplements, antidepressants, diuretics, and antihistamines, are known to significantly slow intestinal motility. This does not mean you stop your medications. It means you have a direct, specific conversation with your physician about your bowel function. Ask him or her plainly, could any of my current medications be contributing to constipation? And if so, are there alternatives with less impact on my digestive system? Many physicians simply do not raise this subject unless you do. You need to be the one who brings it to the table. Number 4. Be careful with stimulant laxatives. Stimulant laxatives, the kind that chemically force the intestine to contract, are useful in short-term situations. But when they become a daily habit, something clinically significant happens. The intestinal muscle begins to depend on that external chemical trigger to initiate movement. Over time, without the laxative, it simply does not contract. This is called cathartic colon, or laxative dependency. It is far more common in older adults than most people understand. If you have been using stimulant laxatives daily for more than 2 or 3 weeks, speak with your doctor before stopping abruptly. Work together to taper off them and rebuild natural motility through the methods I have described here. And if you have made it this far, type the number 4 in the comments. It is a simple way to let me know you are here and still following along. Number 5. Establish a consistent bathroom routine. Your body operates on an internal clock, and your digestive system follows circadian rhythms, just like your sleep cycle. The gastrocolic reflex is strongest in the morning, particularly within 30 minutes of waking and within 30 minutes of eating breakfast. Use that window every single day. Go to the bathroom at the same time each morning, whether you feel a strong urge or not. Sit down, relax, and give your body 5 to 10 minutes. Over time, typically 1 to 3 weeks, your body begins to synchronize with that routine and initiates movement on schedule. Consistency is the training mechanism. Do not skip days. And finally, posture matters more than you think. The human body was not designed to defecate from a seated position with the thighs at a 90-degree angle to the floor. Physiologically, a slightly squatted position, thighs angled upward toward the abdomen, fully relaxes the puborectalis muscle, a sling-like structure that otherwise creates a natural kink in the rectum. A simple step stool placed under your feet when you sit on the toilet, raising your knees above hip level, can meaningfully ease the mechanics of evacuation. It sounds too simple to make a real difference. But for many people, especially older adults with weakened pelvic floor muscles, this single adjustment produces a dramatic improvement. Before I close, I want to address those of you who may not be watching for yourselves, but for someone you love, an aging parent, a spouse, a sibling. Because fecal impaction is disproportionately common in bedridden or mobility-limited elderly individuals, and the people who recognize the problem first are often the caregivers. If you are caring for an older adult who has not had a meaningful bowel movement in 3 or more days, who is complaining of abdominal pressure or lower back pain, who seems unusually uncomfortable, confused, or agitated, do not assume it will resolve on its own. The stakes in a frail, elderly individual are higher than in a younger, otherwise healthy adult. Their intestinal walls are less resilient. Their ability to communicate the severity of their discomfort may be limited, and the cascade of complications I described earlier can progress more rapidly. Proactive steps include offering warm fluids frequently throughout the day, gently assisting with movement or repositioning to encourage abdominal stimulation, and using a glycerin suppository early, at day 2 or 3 of no movement, not day 6. If there is any doubt, contact their physician or bring them in for evaluation. A simple abdominal X-ray can confirm the presence and extent of a fecal impaction in minutes. Do not be embarrassed on their behalf. This is a clinical medical reality that affects a significant percentage of elderly adults in both community and care facility settings. The conversation may feel uncomfortable, but the consequences of silence are far worse. Let us recap the most important points. A fecal impaction, stool that is physically stuck in the rectum, is not a minor inconvenience. It is a serious medical condition that develops gradually, disguises itself with confusing symptoms, and can escalate to life-threatening complications if ignored. The warning signs to watch for: persistent rectal heaviness and difficulty passing stool, overflow liquid discharge that resembles diarrhea, difficulty urinating, lower back pain, and, in older adults, unexplained confusion or agitation. The response protocol: stop straining immediately. Use 2 to 3 adult glycerin suppositories with generous lubrication, lying on your left side, and wait a minimum of 30 to 45 minutes. Repeat once if necessary. If home measures fail, go to urgent care or the emergency room. Do not wait. For long-term protection, prioritize water intake above all else. Move your body daily. Review your medications with your physician. Avoid laxative dependency. Establish a consistent morning bathroom routine. And use a footstool to improve your posture on the toilet. Your digestive health is not a small thing. It is deeply connected to your energy, your immune function, your mental clarity, and your overall quality of life. And yet it remains one of the most consistently neglected areas of senior health because people are too embarrassed to talk about it. Well, we just talked about it, and I hope you walk away better informed, less alone, and more equipped to take action. If this video helped you, hit the like button. It helps this information reach more people who need it. Share it with someone in your life who might benefit. Leave your questions in the comments, and I will do my best to get to them personally. And subscribe to this channel if you want to keep receiving clear, direct, no-nonsense senior health education, the kind that respects your intelligence and does not hold back what matters most. Take care of yourself, drink your water, and take what you have learned here seriously, because your health is worth that.